Hello, a very warm welcome to all of you on behalf of CAMH. Good morning, good afternoon. We have people joining us from coast to coast to coast to have this very important conversation on aging with mental health in mind. We're so glad you're here. We all come here with very different reasons of things we're curious or concerned about, and whatever brought you here today, you are in the right place. There's just a few housekeeping things that I would like to bring to your attention. First of all, I'd like to introduce myself. My name is Donna Bishop. It's my pleasure to be moderating today. Yes, you will receive a recording of this webinar, so ease off if that was a concern. There are two functions I'd like to draw your attention to at the bottom of the screen. One is your chat function. That is a way for you to interact with everyone here today in real time. It is a public-facing function. The second one is the question function. Lots of us might have come with a question we know we want to ask. We will have a Q&A section after the formal kind of discussion with our medical experts today. You can pop a question in there anytime. You're welcome to put it in there now. You can put it in as things come to mind as you listen to the conversation today. That is a private place. We won't be able to give personal diagnosis or medical advice today, but we definitely will speak to common themes and general guidance whenever possible to support you as best we can today. As we come together from many different places today, we want to take a moment to acknowledge the land on which CAMH operates. Even though we're not physically there today, it remains our responsibility to honor its history and significance. We acknowledge that CAMH is situated on the lands that have been occupied by First Nations for millennia, lands rich in civilizations with deep knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds for the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805 with the Mississaugas of the Credit. This vibrant city is now home to a vast diversity of First Nations, Inuit, and Métis people who enrich our community immeasurably. CAMH is deeply committed to reconciliation. We honor this land through programs and spaces that reflect and respect this heritage. We embrace the healing traditions of the ancestors, weaving them thoughtfully into our caring practices. And we commit to building meaningful relationships and partnerships with First Nations, Inuit, and Métis peoples, sharing this land and protecting it for generations to come. So let's get into the conversation. Thank you so much for joining us today. It is my pleasure to introduce you to our medical experts. Today we have Dr. Eric Brown. He is the Associate Chief and an inpatient psychiatrist in the Geriatric Psychiatry Division at CAMH. And we also have Jardane Holland, who is the Clinical Director for Geriatric Mental Health Services, Adult Neurodevelopment Services, Social Support Services, and Medical Affairs here at CAMH. We have very busy people here today. Thank you so much for joining us, Dr. Brown and Jardane.
Thanks so much. It's a pleasure to be here.
So let's jump right in there because we're going to be covering a lot of ground today. What I think would be a great place to start is, Jardane, maybe you can start us off with just giving us a landscape of dementia versus Alzheimer's versus cognitive decline. What are the definitions of these health conditions, these mental conditions, so that we are all kind of on the same page as we have our conversation today?
Absolutely. So thank you for having us. And we're really excited. Of course, this is a topic near and dear to our hearts and things that we're invested in every day. Dementia is an umbrella term, which means talks about many different possible illnesses. And so it is a neurological degenerative condition. And the most common reason for dementia is Alzheimer's disease. And that's the one that most people is aware of. And most people associate that with memory changes, particularly short-term memory changes. But dementia can mean changes in many different parts of functioning and cognition. So this could be change in behaviors, change in mood, and change in a number of things. There are many also other types of dementias. And so it's important that when you're seeing that there's changes in the way that you would see who you are as yourself, that you are reaching out early and thinking about how to get some advice about what would be considered normal or what you might need help with, either through mental health supports or cognition supports.
And we're going to get to that piece of early detection and prevention in a second. But Dr. Brown, I'd like to throw this one to you because I think what brings so many people here today is getting a sense of that understanding of, if I see a change in a loved one or perhaps in myself, what are the ones that should set off alarm bells and be very concerning, and which are the ones that perhaps are not concerning and are a part of the passage of time. Like, we all, forget where we put our car keys sometimes. How do we know what is cause for concern and what is not so much?
Yeah, that's a great question, and a challenging one to answer too, because it can be the case that a lot of the symptoms of dementia can also occur in normal day-to-day life. And we're talking about symptoms on a scale of severity. So for example, it's common, as you mentioned, to forget, where you put your keys, or to have trouble coming up with someone's name if you haven't, heard from them in a while. That's a day-to-day experience in adults and older adults. And it may actually become more common with aging. And there's a certain degree of cognitive decline that's expected in aging that can occur. And then it's also the case that sometimes people are having more symptoms than they themselves are even aware of. So they could have, for example, changes in their memory. They may repeat themselves in conversations, and it's the caregiver or the loved one that starts to notice these symptoms before the person is. And you can have the flip side, where someone can be really worried about all sorts of changes they think they're seeing in their life, or they are noticing in their life. And they go to the doctor, and the doctor says, hey, actually, everything seems to be pretty fine when we do any testing. And we call that subjective cognitive impairment. So it can be pretty tricky, but I think the bottom line is, if you're starting to notice changes in cognition, so this can be things like short-term memory, forgetting things, getting lost, forgetting where you put your belongings, changes in language where you're having trouble forming sentences or coming up with the right words, troubles with complex planning, so your banking isn't going so well, or you're having trouble with grocery shopping, your day-to-day activities, trouble with mood or anxiety or behaviors in your life, or you've noticed your personality is changing, or your friend's personality is changing. If those start to worry you, it's fair to go to your family doctor to ask and mention these things and see, is this something that is worrisome? Is this something that needs further attention? And there's screening tests, there's things that can be done to make that determination of whether this is serious or not.
So, what I hear you saying there is, it's actually not a clear path of like, this symptom or this change means you for sure have dementia or you for sure have Alzheimer's. Like, there are many factors as time passes that can impact how our brain functions, and it's really important to just sort of be aware of them, and family doctors are the first place to go.
That's right. And another reason why it's important is there's other things that can make someone's cognition not as good as it used to be, that aren't dementia. And many of those things are reversible as well. So difficulty sleeping, depression, drinking too much alcohol, other nutritional difficulties. So that's why the family doctor should really be a point of contact to get that fulsome, holistic view of what's going on in someone's life and someone's medical condition that might be contributing to concerns about cognitive changes.
Well, and that brings me to something that you touched on a little bit just in that first question, Jordan, which is early detection and prevention. How important is it to have that early detection?
Yes, so we know that it's really important to get help and seek attention as soon as possible if there are serious concerns of the symptoms that Eric mentioned. And in particular, because There are some kinds of dementia that are reversible. So it could be some deficiency or other things that Eric mentioned. That could also be quite serious. An example is having a delirium. So you might have a urinary tract infection or other reason that could cause a delirium that is a medical condition that needs attention. But the other is because there's actually a number of modifiable risk factors for dementia that we can all do as healthy adults to try to prevent dementia. We know that up to 40% of dementias are actually preventable. And these are new breakthroughs in understanding about dementia that we've recently learned in the last number of years. We also know that there are ways now that we might be able to slow the progression, even if you do have a mild cognitive impairment or an early stage dementia, that we can actually do through modifiable lifestyle factors, but also through treatments and investigations that can actually help us to slow the progression and to increase the quality in our years and the quality of living with dementia. So for all these reasons, it's really important to get a diagnosis or seek care as soon as possible. The other reasons are social reasons and really life reasons. So when you are equipped with knowledge and you understand what the potential change in your life is going to be, you can plan for yourself and with your family and friends and loved ones, and also think about and prioritize what matters to you and how you want to live your life, and make sure that you can get, again, the best quality of your life as possible.
Jordan, I heard a collective kind of exhale and shoulders relaxing when you talked about forms of dementia that are preventable and reversible, because I think there can be this assumption that it is a bit of a prison. Like once you walk down that road, you are there for life. Dr. Eric, can you talk, Dr. Brown, pardon me, can you talk a little bit about the preventability of things before we get into some of those lifestyle factors?
Sure. Yeah. So the key is early on in the course of cognitive impairment, if you can identify that things are changing, there's more opportunities to change the risk factors that contribute to cognitive impairment. So these risk factors actually occur across the whole lifespan. And so there's things that people can do in their younger years to try to reduce the risk of dementia. And these are things that span biological factors. So people are generally familiar with cardiovascular risk factors, things like smoking and cholesterol and diabetes and exercise. These factors all increase the risk of dementia as well. So if you can treat those, prevent those, then you can change the course potentially of your health and reduce the risk that you'll eventually get dementia. But there's also things that can be done after someone's already started to notice some changes, things that are contributing to risk even in mid and late life. Those are things like visual and hearing impairment. It's very important to identify those early and to treat those. We're learning that social engagement is key and that loneliness is very bad for the brain, very bad for dementia. And maybe 5% of cases of dementia could be attributable to loneliness. So if we address that, we could reduce the number of cases that we see. And then the medical conditions that can contribute are also potentially things that can be treated. So if someone has what we call a vascular dementia, if their heart disease and vascular risk factors like high blood pressure are well treated, then it may no longer progress. It may stop or slow the progression of a dementia related to that. And then there's medication treatments that can be used for the more common types of dementia like Alzheimer's, which can also delay the progression of the illness or improve cognition so that it stays better longer. And in an illness that affects people in late life, delaying the symptoms is very, very important for people. It preserves their function and their quality of life for longer.
Well, okay, there's so much there I want to unpack with you, Dr. Brown. Can you go back a little bit to when you were talking about hearing impairment? Because I feel like that's something that, we think of it as, oh, that's just part of getting older. My hearing's going, my parents' hearing is going. Why is that such an important thing to keep tabs on as it relates to dementia specifically?
Yeah, that's a good question. So think of the brain as something that takes inputs from the world and does things with it like a computer and then provides outputs. If you don't have the proper inputs, if the inputs aren't working properly, the brain stops working well, right? So our vision and our hearing, that's the way we experience the world. That's the stimulation that the brain gets and the brain needs to stay active. So we talk about, keeping the brain active and doing activities. Well, if you're not able to experience those fully, if you're not hearing conversations, how can you be engaged in them if you're not catching things? So I think people who can't hear well or see well tend to disconnect more and have trouble with those meaningful social interactions, those meaningful experiences in the world. And that's probably why it's contributing to cognitive decline. So that's something that in many cases is something that can be reversed, identifying the cause of the hearing impairment, using a hearing aid, using various strategies to improve someone's some senses is key.
And I can see how that hearing impairment would impact a comfort or an opportunity to socialize. Jordan, can you talk a little bit more about the importance of socialization? And because I think that's something we're hearing a lot about, like even in our news feeds and stuff like that, is like socialization is something we're learning more and more about how important it is. It's not just about doing crosswords or playing chess with friends. Why is it so important to us medically as we get older?
That's a great question. So we know that keeping our brain active is a huge component of staying healthy. And part of it is the loneliness factor that Eric was talking about, but also it's really engaging in the fullness of life and giving your brain all of those different inputs is really important. And when we're in social situations, we're using many different parts of our brain. We're really engaging fully in many levels. And the other thing is that socialization is really crucial as human beings for well-being, which is also really fundamental to potential deterioration. So we want to make sure that we're engaging fully with a variety of social situations. It actually, in the evidence, shows that socialization is more important than, let's say, brain teaser puzzles or other types of things that you hear. Oh, check out this app
Yeah,
or
I got
do
my
these different
Sudoku, I got
activities.
my connections, I
Right.
got my crosswords.
Right. So although those things are all very good in keeping your brain active, if you were going to choose between going out to the museum with a friend or staying home and doing crossword puzzles, it would be leaning more towards the social factor in terms of getting all those different inputs to be able to continue to exercise those different parts of your brain.
And it must be almost like it must be, I don't want to say easy, but I can see how social interaction could easily start to slip away kind of without noticing it as perhaps a work situation changes. Maybe there's a retirement, perhaps a loved one that someone would see all the time has moved or passed away. Like, is it important to kind of just keep tabs on the architecture of a loved one's life or maybe our own life about where those social interactions happened kind of without us thinking about it, and then maybe having to be more conscientious about reintegrating them?
Absolutely. So I think Dr. Brown and I would agree that there are sometimes major life events for people, especially older adults, a death of a spouse, for example, retirement, a change in, let's say, one's physical ability that all of a sudden you're thinking that, this has changed the course of my life. And I think those are the times where we might want to spend some extra time checking in on our family members, checking in with our friends to really support them, because it can start to, make that person a little bit more isolated, and they may make changes over time that will make them more predisposed to saying no to really engaging with life. And that's putting them a little bit at risk for not just dementia, but other mood disorders or even physical health conditions that we want to promote, of course, continued well-being.
Dr. Brown, how big a component is genetics as it relates to dementia? Is that something that if we know our parents or our grandparents had it, that it's something that we should sort of assume we are of higher risk of having ourselves?
Yeah, so there's a lot of different genes that can contribute to the risk of dementia. The ones where you have an early onset case, and I would say that's before 60 or 65, uh, those are rare types of dementia. They can be associated with genes that have a very high risk of leading to dementia. So if you have a loved one who develops that rare form of dementia early on, they may be offered genetic testing, which could inform your own risk if you're a relative to them, if you have that gene as well. The vast majority of dementias are occur in late life, so after age 65, and there are genes that are associated with those conditions, but the degree that they increase your risk is much lower than those rare early onset cases. So it's not inevitable if your parent develops dementia in late life that you also will get dementia, but they may have a gene that does increase your risk maybe 2, 3, 4 times over the general population if they have the gene and you also have the gene. That testing isn't always done, but sometimes it can be helpful. The important thing to consider is that's an opportunity to know that your risk may be elevated, and it becomes even more important to have a look at those preventative opportunities and risk factors.
So going back to the lifestyle factors and the preventative things that are, healthy for us generally as time passes, but it sounds like we know even more about their impact on our brain and how powerful they are in terms of preventing and slowing down dementia.
That's right.
Believe it or not, we only have a few minutes left of this part of our webinar. So I just want to remind our guests here today to put questions they have in the chat, because we are going to be in the question function, because we will be opening it up to the Q&A very soon. But Jordan, you mentioned something earlier that I think, kind of can't be overstated, which is the mental health component of all of this. Mental health is something we talk more and more about in all aspects of our life, rightly and wonderfully. How does things like anxiety or depression present differently in our loved ones who are aging? What do we need to kind of understand or keep an eye open for?
Thanks. And it is really important, of course, to talk about mental health and also in older adults. I think for some of our older adults, there's still a stigma related to seeking care and seeking help, whether it's for mental health or cognitive changes. So it's really important to open up some of those conversations about concerns the person might have, the older adult may have, or have those supportive conversations as friends or family members, and really just take the time to listen, not really judging or putting any pressure. I think a lot of the stigma is also when you're an older adult, you may feel more vulnerable. A lot of people express being concerned about accepting help because there might be judgment about being dependent, for example, and not having their autonomy and independence and dignity really, protected as older adults. And so just being a little bit more open and sensitive to the fact that they might be a little bit more scared to open up about their concerns. And also to know that there is help out there, there's supports. And so places like CAMH, and we have happy to talk about our programs later, but we have supports available to you to seek help for your mental health or for your cognitive changes, and for both, if in some cases.
We'll definitely be touching on those resources before we leave today. And you mentioned something, Dr. Eric, Dr. Brown, can you talk a little bit about how depression and anxiety, like they can be a cause or a symptom, it sounds like. Like it sounds like I could be experiencing signs of dementia and that leads to depression, or I could be depressed, which makes me maybe be more isolated and not want to move my body as much, and then it can exacerbate the symptoms. Like it sounds like there's a very powerful dance between mental health and cognitive decline.
Yeah, that's right. So we consider depression to be a risk factor for dementia, and we also know that people with dementia are much more likely to get depression, and it can be, in that sense, a symptom of their dementia. depression is a really important thing to address, right? Especially in the elderly. You're asking about unique things about depression in the elderly, and one of those things is it really does need to be addressed. If it's not treated and not addressed, it can linger on for a very long time, and sometimes it doesn't get better. So seeking treatment for depression can be very important. The symptoms of depression include things like social isolation, include not taking care of yourself, include withdrawing from the world. And in that sense, they also increase the risk of the other risk factors that lead to dementia. And of course, just a low quality of life in and of themselves. But they also share biological changes in the brain. So it's very important to recognize the signs of depression, which, in the elderly could be the classic symptoms like in a younger adult of low mood and guilt, but could also show up in unexpected ways. A lot of physical symptoms or lower energy or withdrawal or not engaging in the activities that they liked to do before or the people they used to see. So those changes are again flags that something's going on. It could be a medical issue, it could be depression on its own, it could be dementia, it could be a whole host of different things, and it's important to seek medical attention if people are noticing those changes in their lives.
Well, and as you're talking, the mental, and this, I'm going to open a can of worms, which could be, 2.0 of this conversation, which is the mental health of the caregiver. I think there are probably many people here. This is certainly the situation that I am in, where I have a parent who I'm worried about. I'm having to do more things for them. I'm having to, anticipate appointments and helping them keep in contact with friends. The toll of the caregiver from both a mental worry place as well as a physically having to execute for a loved one can be incredibly significant. Jordan, what do you see in your practice as it pertains to the mental health of the caregiver? And, in just a few sentences, what would you like us to talk about in terms of that as this pertains today?
Absolutely. I think the well-being of caregivers is such an probably an under-recognized and under-acknowledged area, sometimes called the silent or the unseen patient. And I think most of the time when we're working with older adults who have cognitive impairments, we are treating what we call the dyad, or the caregiver and the person with dementia. Most caregivers, they've calculated the average in the latest Alzheimer's Society of Canada report, spend an average of 26 hours per week, which is equivalent to a part-time job, and some more than that, caregiving. And that, again, lasts on average from 3 to 5 years and sometimes more. And so that the experience of caregiving, while it can also be an incredible meaningful experience in terms of making sure the person has the best possible care and that you're able to really live in the moment with the person with dementia and get to enjoy that. It also can be extremely isolating, extremely stressful. Most caregivers talk about feeling burnt out or being exhausted. And that does put the caregivers themselves at more risk for developing things like depression, anxiety, other physical conditions like diabetes. And that, of course, the caregiver is so essential to the well-being of the person with dementia in the community, that if the caregiver is not well, it actually puts the person with dementia at risk for worse outcomes as well, including, going to hospital, going to long-term care, and other things that may not have been in the goals initially, although sometimes are very, very important to be able to receive the kinds of care that is needed. So I think this merits a whole discussion on its own, but I will say that there's really also a stigma for caregivers in reaching out and getting help. And it's really important. And I think the thing to take away is, if you are a caregiver, you're needing support, to reach out and get that support as early as possible. Also to get safe spaces, both socially and personally, as well as maybe through formal means, through support groups, education groups, to really be able to build that community and to get respite as often as you can.
One of the first things I think, and thank you so much for acknowledging so much of that. I think so many people will feel incredibly seen with what you just shared, with the toll and the weight that caregiving can be. One of the first things I think a caregiver ends up doing is they're the ones that often broach the conversation with a loved one about a concern. And I'm wondering if you have any insights into what are some kind of best practices or advice on how to open that conversation with someone you love who you notice, might need to have a doctor's appointment with this particular lens in mind, let alone perhaps something more serious where you feel like maybe driving isn't something that would be a good idea anymore, or, a living situation might change. How do we start those conversations with our family and loved ones?
Yeah, so these are very difficult conversations. In general, I think it's important to have those conversations with people about what's important to them, what they like as early and as often as is possible. But when you're in these situations and you're trying to work with someone to go and receive help, part of cognitive impairment sometimes can be a lack of insight or not actually knowing that there is a problem. So uh, they may not know that they don't know in that way, or they may
Yeah.
not remember that they don't remember. And
Yeah.
so that actually presents a unique challenge for dementia care, where that is not necessarily present in other types of illnesses or aging conditions. And so I think really acknowledging that the person may not be trying to be difficult or may not be in denial. A lot of caregivers talk about the person is in denial. Well, they actually may not know or not have insight because of their condition about what's changing for them. And so just to have a little bit more kind of compassion in that. And lastly, that there are things you can do to prepare for a doctor's visit. There are checklists that you can use to try to be ready for that. You can also talk to the person about just wanting to support their well-being in general, and that it's really important, and that you've heard that there may be changes that can be addressed, and it's important to check out all of those reasons to try to depersonalize it a little bit and make it much more about their well-being. But I would underscore that every situation is different and unique. And if you want advice about how you might be able to support that particular person, you can always, again, reach out for help, and happy to provide resources on that as well.
It can be so frustrating because I think so often those early signs, we're only human, right? We're often meeting those signs with frustration with our loved ones, like, how did you not remember that? And why aren't you? And it's hard not to be hard on yourself when you realize that perhaps you reacted initially with frustration and maybe even anger, and hopefully the caregivers here today will give themselves some grace, because there's always the next day, right? Dr. Brown, we hear a lot about treatments. Like there's a new drug that I think has entered, the conversation in Canada just recently. What is exciting you about dementia treatment? What is keeping you hopeful when we look at the future of treatment of this disease?
Yeah, that's a good question. So the the treatment landscaping is changing very quickly. I mean, one of the good news stories here is there's a lot of attention and people care about dementia. So there's a lot of really exciting research going on into new treatments and new diagnostics to help people figure out what's going on earlier and to do something about it. So one of the new classes of treatments that's become available in the United States and just recently was approved in Canada is a medication that specifically targets what's wrong in the brain in Alzheimer's. So one of the things that goes on in the brain in Alzheimer's is amyloid plaques. And these medications, they're mostly given by injection. They enter the bloodstream and they bind to these amyloid plaques and they help clear it out. And they're very effective at clearing it out of the brain. It seems that this also leads to improvement in cognition, not a full reversal of dementia at this point, but the treatments are getting better and the protocols are getting better as well. So there's hope around this whole new field, and there's other related medications in the pipeline. So the medications currently are a bit cumbersome to use. They take a lot of brain scans, and as I mentioned, they're given by injection, and there's a lot of infrastructure that needs to be developed around these medications to make sure that they can be given safely and effectively and appropriately in Canada. So we're not there yet. You can't go to your family doctor, you can't go to a memory clinic and receive this medication routinely yet, but it's right around the corner. And as I mentioned, other medications are as well. So that's one. It's called lecanemab. But there's other medications that are currently available that also help reduce the burden of cognitive and related symptoms in dementia. And these are pill medications or patch medications that can be given. So I do want to dispel the notion, like sometimes you ask why people don't seek care. It could be for a lot of reasons. It could be because they don't think they have a problem, but it could also be because they think nothing can be done. Nothing can be done to help them. And that's simply untrue. There's often lots that can be done, both to address risk factors and contributing factors and optimize someone's health, but there's also medications available that can slow the progression of symptoms and preserve that quality of life.
That is such a hopeful note to end this part of our conversation on. We're going to move to the Q&A, but right before we do that, Jordan, if people are interested in the resources at CAMH, if they are looking for something in their communities, where would you recommend that people go to seek more information?
Absolutely. So we're really lucky here at CAMH to have wonderful experts like Dr. Eric Brown and many others. We do have a wonderful array of outpatient services. And so if you are concerned about either cognition changes or mood changes, we do have our memory clinic, but also our general mood and anxiety clinic. So you can work with your primary care provider to make a referral to CAMH and to our outpatient services. We also have inpatient services and other types of services that we can connect you with in the community. In the community, we have also partnerships with the Alzheimer's Society of Toronto and other chapters that will really be able to provide kind of the education and social supports. I mentioned things like support groups or respite programs. These are really essential to really understand what the journey of dementia is like for the person and for the caregiver, and how to best prepare and also to best live a life that can be meaningful and for both the person and for the caregiver. So just please reach out to CAMH and to our community support services, and we're also happy to chat in the Q&A and link with you individually if you have any more questions.
And those of us who are here today will be receiving a toolkit with the recording of this webinar that will have additional resources and whatnot there. So if you're here today, you will be getting some really great follow-up with where you can go for more support. I'm going to move to the Q&A because it's coming in hot. And the first question is quite juicy because it talks a lot about like testing and whatnot. So I'm going to throw this one to you, Dr. Brown. What can we do when we recognize memory difficulties in ourselves, but conventional testing has had negative results? And equally, what if we are noticing early onset dementia in a loved one? Are there tests that can be done, or what can be done if we are noticing things?
Okay, great questions. Two separate questions. So I'll walk through some of the general things that can be assessed when someone's worried about having cognitive impairment in themselves or in a loved one. So if you were to go to your family doctor, you might expect that they take a detailed medical history. And the reason is they want to find out all the things that could be contributing to having cognitive impairment. So dementia is one of them, but it could be depression, it could be nutritional, it could be some other medical issue. So they'll do a medical history and probably a physical exam and maybe some blood work to look at things like your thyroid and your B12 level, your iron, your general blood work and general state of health. Then you might also do a cognitive test, and that's, I think, was alluded to in the question. So there's a lot of different cognitive screeners that can be used. And if someone has only mild symptoms, they'll pick a screener that is more designed to detecting mild symptoms. In some cases, people score okay. And even if they're worried about forgetting things or their memory, and they do okay. And this is known. This is a thing. So it's called subjective cognitive impairment. Someone subjectively feels like they have cognitive impairment, but the tests aren't kind of reflecting that. It's should be reassuring, first of all, but it's also still good to pay attention to that, and to pay attention to all the good health practices that predict that promote good brain health, good cognitive health. So there is an increased risk of later developing detectable cognitive impairment if someone has subjective cognitive impairment, but it's not inevitable that that's going to happen, and it's not dementia, and it's not a foregone conclusion. So just sets the stage for the importance of prevention and good health.
Well, and that subjective cognitive impairment, I imagine, must have or could have a significant mental health component because you're feeling diminished or you're feeling like something is not working, like your experience of your own brain, while it might not be medically determined a crisis in that moment, you are still feeling like you are not yourself.
That's right. And even though it's a relief that the tests are showing things are normal, it's still very concerning, right? It's almost invalidating. Like, well, I know something's wrong, but the tests are saying everything's fine. So what's going on here? And so, yeah, thinking broadly about things like depression and anxiety and other potential factors that can lead to someone to feel that they're experiencing those changes, or recognizing that those changes can happen and can be normal and don't necessarily indicate that there's dementia around the corner, or that's where someone's going to progress. So if the concerns that someone's experienced are significant, they could think of they could think of strategies to compensate for them, or ways in their life to diminish the impact that they're perceiving that those symptoms are having on their life.
Jordan, we have a question more around caregiving. How can I handle my own feelings and anxiety when talking to and guiding my loved one through their declining mental abilities?
Yes, and this is, as we started to talk about, it can be very challenging. So I also want to recognize that everyone has their own unique also kind of relationships with the person that they're working with. So we often recognize there are histories there are family dynamics, there are also, again, there may be lack of insight or other types of feelings. I just want to acknowledge that all feelings are very valid and very okay. You might feel angry, you might feel guilt, you might feel, stressful. It also might be a relief when you get a diagnosis. There are so many different things, and all of those feelings are okay. But it's really important also to recognize that there is a unique situation. So I would support that person to go and reach out for help, to talk through their unique situation, but also to strategize around how to kind of navigate moving forward and working with that person in their life. There might be things that or approaches that might work better for that particular person, that they may be as a person just more sensitive to as part of who they are, and some strategies that may be more effective than others in seeking help. And then lastly, I would say is there's a lot of work in terms of supporting yourself and your own well-being, whether that's counseling or therapy, whether that's, again, having your own social connections and people that can really understand your experience. Sometimes as a caregiver, your friends and family, although you can confide in them, may not understand your experience as a caregiver because they haven't had that same experience. And so talking with other caregivers can actually really be validating and supportive, because there's an inherent sense of knowing what you're going through.
It is such a situation where we bring all of our baggage and all of our special sauce and all of our family dynamics to a very real situation that sometimes can feel like if we as the primary caregiver don't do whatever the thing is, then nothing else will happen. Like it is a very complex emotional situation, to be sure. Dr. Brown, we have another question that is about like kind of the Venn diagram of other medical conditions that can be happening at the same time. So this person asks, how can one distinguish if mood disorder or dementia is at play, is seeing that symptoms can overlap? For example, what if the elderly parent is experiencing short-term memory challenges during post-chemotherapy recovery? How can we differentiate symptoms when other things overlap?
Yeah, that is a good point, and it's a challenging situation for sure. Being on chemotherapy can influence cognition, and it can also influence mood, let alone the experience of going through treatment for cancer and the recovery process.
Yeah.
So all of these things, medical conditions, serious medical conditions, depression and dementia have an overlapping presentation. They all can impact symptoms like energy level, concentration, memory. Um, and so sometimes it's too tough to call, actually. And so sometimes the best strategy is uh, to do your best to get treatment and address the underlying issues, address the depressive symptoms, make sure that the medical condition gets the proper treatment, and see it through, optimize diet and exercise and lifestyle factors as good as possible, and to pay attention and to reassess. Sometimes it takes multiple assessments over time to see, is cognition getting better as depression gets better, or are things continuing to progress? So sometimes we can't make the call if there's a dementia emerging at the same time, because there's other good explanations for why someone's cognition might be impaired.
We're getting ready to wind down. We have time for just a couple of more questions. And this one is asking about how can one best support a spouse of the individual with Alzheimer's or dementia, especially when when it's at a critical level and we're waiting for space in a facility? Jordan, I see you nodding like, yes, that struggle is
Yes.
very real.
The struggle is real. And so I think, well, first of all, I want to applaud you because I think you're thinking of your friend. You're wanting to be there for them at this very difficult time. And that's really important at a time where they will be struggling. They will be, really trying to figure out what supports can be in place and what's best for them. And so I think sometimes just talking to them and being that listening ear and a safe place for them to really be to share all the good, bad, and ugly of what it's like. I would say social supports are extremely important. And then the other one might be concrete things. So whether or not you can help provide respite to that person, whether it's spending time with the person with dementia yourself or linking them with resources that can offer some respite. Oftentimes, respite is also quite challenging. It might be costly, or there might be individual concerns. The caregiver might be feeling anxious or guilty about taking respite. There are also lots of other kinds of supports, home care supports that may be able to be provided, or adult day programs. So there's a whole host, but I think it's really individual specific, and really being that listening ear and trying to navigate that with them and helping them also to receive support and feeling okay about receiving support is really important. But I would say that the number one thing is to help them not to feel alone in these very difficult times.
You can see how it easily becomes a 26-hour a week job when sometimes just the research to find out what to do next can be so incredibly time consuming for loved ones. We're getting down to our last questions. And this one is talking about, they acknowledge that we've talked a lot about the importance of socialization. But what if someone is naturally introverted? Like they're not someone who has gone out of their way to be social in the past. Is this something that then we should be encouraging our loved ones to do more, or kind of like forcing them out of the house a little bit? How do you find that balance of what they were naturally inclined to do and what is best for them in this moment?
Yeah, that's a good question. And there's a lot of forced socialization that occurs in kind of middle adult life. If you're working, you go to work every day and you see lots of people, and whether you like it or not, you're having conversations and having some fun and going to some events. There's a lot of changes that happen in late life that can decrease one's social circle. So it's not only if you're not if you're not inclined to be very social, it's that it won't happen. But even if you were someone who was social, you can find yourself all of a sudden more alone, and it actually takes active effort to maintain that social circle. I would say you can't really force anyone to do anything, and it's if someone doesn't didn't go to parties and didn't socialize very much when they were in their 40s and 50s, it may not be that that's the thing that they're going to do all of a sudden in their 60s, 70s, and 80s. But there probably was some element of social connection in their life in some manner, and it probably played an important role, and maybe a bigger role than they themselves were aware of. So sometimes it's helpful to take inventory of what was it that what kind of relationships did I have? What kind of encounters did I have in previously? And am I feeling worse now? And is that because there was some need being filled that's no longer being filled? There's something missing. And then coming up with a strategy to address that need that makes sense for the person, right? So maybe it's not, going bowling, or but maybe it is having a chat with someone once a week, or or more than that, or maybe it's doing something that's a bit of an individualistic activity, but it still involves social engagement, like taking a class, or learning a musical instrument, like different ways to get that social engagement that makes sense for the individual. Usually people do like some kind of social engagement. It's a matter of like in what context and what structure, and often it's very important to pay attention to what's missing, and come up with ideas on how to get there. So I would say if you're trying to help someone, your ideas might not be the best ideas. It might be a matter of helping them come up with their own ideas to find things that work for them.
Is there, when we talk about exercise, we often hear about a prescriptive of like 3 times a week for X amount of time. Is there anything similar for social interaction, like where we know if you do it at least once a week, that has benefits? Or is it a little more zen where it's like any is good and we don't really know what the goalposts of optimal time are?
I personally don't have a number that I tell people, and I think it's again more of looking at that need and what's missing and what's changed, and figuring out how to fill that need, and how someone can find some activity or level of social engagement that works for them. But I will say what we learned in the pandemic is that even a phone call is super valuable. Even just a touch base is helpful. So it can have a measurable impact on someone's mood and level of loneliness, but also on their cognition and general health if they have that regular connection with someone. So if that's all the person is willing to do, or if that's all that is available, that's better than nothing. And sometimes people find connections um, in in small interactions, spending some time, in a community center, or in the lobby of a building that they live in, or these small encounters can have a powerful impact in people. So again, it's so individualistic, but anything is better than nothing. And the more a person is able to do and wants to do, the better, I would say.
Well, and it sounds like not to devalue a phone call or maybe an online class. Like if people aren't in a place like, it's the weather is crazy across our country right now. So even if you can't get out of where you live, doing something that might be interactive digitally is still something.
Absolutely. And I think in particular, during the colder months, because we do live in Canada, we are seeing that winter actually, it does increase social isolation for older adults because they're more reticent of, slipping and falling, or, driving in bad conditions, which is completely understandable. So really having things that they can do that they feel comfortable with, to Eric's point, that they feel like this could be doable is really important. So even saying, if you don't feel comfortable coming out, let me come to you. Let's, let's bring a takeout, or let's do book club, or let's, do something else that might be more feasible.
And then our final question is someone who, is thinking of the treatment and even the facility environment. There's so much we hear about wait lists for referrals, for facilities. What is the best practice to kind of truncate that process for people? Like, is it still just going to your family doctor first and taking it from there? We hear so much about how hard it is to get into the next phase.
Absolutely. So I do think we are at a point where navigating healthcare systems for older adults is very, very challenging, and people often need supports to do that. As well, I think people have an expectation that sort of if we're in a time where we need those supports, we're really lucky. In Canada, we have publicly funded healthcare, but it's really important to know that there actually are wait lists and there are processes to go through, and to start planning a little bit earlier for those different potential outcomes. So what we're seeing in at least long-term care is that people can wait years actually in community waiting for long-term care. So although people feel like that may be the last resort, if we know that dementia is a progressive degenerative illness, and that, the supports to remain in the home may not be there, it is important to have some of those conversations with your family and to plan ahead a little bit, and to engage with your family doctor, but also with other supports, community supports, home care supports, and thinking about wait lists for long-term care or other things that might be beneficial to start earlier. That being said, everyone's situation is different. Your means and your social support circles, that your wishes about what you would like are all different. And so it's important to have those individual conversations. And we're happy to support here at CAMH, of course, with our outpatient programs. But also there are community resources, again, that we can send to have some advice on having those discussions early, planning for the future. And there's also education and training programs for caregivers for those things that might be useful to you as you contemplate the next steps ahead.
Dr. Brown and Jordan, thank you so much for supporting us today with your time and your expertise and your warmth and your openness today. I think there's a lot of relief in knowing that there is prevention and medical treatments on the horizon, and resources for those of us who find ourselves in the midst, or perhaps anticipating supporting someone or navigating this on our own. So thank you very, very much for being here today. Thank you to all of you who joined us today from across Canada. You bringing your curiosity and your openness is, part of why CAMH is here to support you and bring these resources to you. Thank you for all the people behind the scenes who made this possible. It literally takes a village. These conversations are emotional and sensitive and important. And thank you so much for showing up with your most authentic self and your curiosity to get more support. As we continue to mention, there will be a toolkit sent to you with resources, as well as a recording of this webinar. So this is here for you to rewatch and share as you need. CAMH is here to make sure that no one is left behind. And if today's conversation resonated with you and you believe in the importance of expanding access to evidence-based mental health care, there's always a way to take that next step. Every gift to CAMH ensures that people and families get the care and support that they need when they need it. And of course, before you go, there's always one little piece of admin, and that is a really quick survey. I promise it's super fast, like less than 5 minutes. And it just really helps us, less than 2 minutes even. And it really helps us ensure that as we continue to do these webinars, that they serve you as best we can. So if you don't mind taking 2 minutes to fill that out, we really, really appreciate it. Thank you so much for being here. On behalf of everyone at CAMH, we're wishing you a wonderful rest of your day. Take care.